this is gonna just be kind of an overview of the skills that we're gonna do this semester that are a little bit out of the ordinary. And I'm not gonna go into too much depth about them. We are gonna go over the pump today though, because I think most of you are like a little terrified. And I feel like, well, we'll go through it. Like, I just think it's already hard when you go into a clinical and you're worried if your nurse is going to be nice in the first place, and then when you can't do your pump and your nurse is like, what a dumbass, you can't do anything, and then your whole day is shot, right? So you're like, okay, I just at least want to know something. I want to have some control, right? So I will give you back that control. We'll go over the pump, and I will go over the pump. Well, Cherish will be your instructor, but I'll talk to her. Anytime you need help, ask for help. If you want to go over the pump every single week, go over the pump every single week. But especially when you're med, get your hands on it and really learn it, because it will definitely give you power. And most of the big hospital systems use the Alaris pump. So some of the small facilities will use different pumps, but the big hospital systems mostly use this one. So we're going to kind of go over IV insertion, the pumps and hanging fluids, Foley catheters, IM injections, and fundal massage. So with our IV insertions, like things to remember, like gauges. I thought I turned my volume down, sorry. There we go. It's just David emailing us all everything. So IV insertion, like what gauge am I going to need, right? And in labor and delivery, for the most part, we're using 20 gauges. Sometimes we use 18 gauges, but you can give blood in a 20 gauge. And it's a little bit smaller than that 18 gauge, so we usually go for that one. And we also have to think too, like what medications are going to be administered, right? If you're like in a trauma patient, you're going to do a bigger gauge, right? And then placement. Consider how the patient will be positioned and moving during labor, and not just labor, but postpartum. If I put an AC in and mom's holding baby, that pump's gonna be beeping the whole entire time, right? You're gonna be occluded the whole entire time. That's annoying. But even now, best practice has been to put in the hand. Even in the ER, they've been doing that. So things have shifted a little bit. It used to be like put in 2 ACs and go from there, but we've kind of stopped doing that. And rule of thumb, where do we start placing IVs? Down to up, right? Like we're gonna start lower, because I don't want to create a hose, right? Where I've already got little holes all over the place. So I'm gonna start from below and then go up. But I also wanna consider what medications are gonna be administered, okay? So there's a medication in labor and delivery that we use quite often that can't be placed in the hand. Do you guys know what that is? That's my IV Phenergan, okay? IV Phenergan can't be placed in the hand. The vessels there can't hold it. It's too caustic. So I have to think about those things as well. Like if I have a patient that really is allergic to Zofran, or the Zofran isn't working and she's super sick, and I end up needing to do the IV Phenergan, then I'm gonna have to place her IV somewhere different, okay? You can put it in her arm. I have a friend who was actually in Idaho at a hospital. She was on vacation out there, and they pushed IV Phenergan in her hand. They didn't dilute it, and they didn't flush it. And she ended up having to get life flighted and plastic surgery because she had a huge hole in her hand from the Phenergan. So there's certain meds that you just have to be careful with. But at the same, those Idahoans. I know. Jeez. You know what? Here, I will have to say, I am a Californian, but the healthcare there is awful. So I'm okay with that.
I think you could go anywhere. Like
Absolutely.
You can find it here in Utah.
Absolutely. So those are just things to be aware of. But at the same time, I wanted to like instill a little bit of fear, but at the same time, I don't want you guys to be terrified. Like, oh my goodness, I don't know my meds. I have to know every single med, right? I think you guys stress out a lot with your pharm class, right? Remember, pharm is giving you a good base of what the base meds are, right? But you are not going to use all those meds, and dependent on what field or what unit you work on, you're going to learn all the meds that you need for that one. So for nursing school, study, memorize those meds, get through the test. Even on NCLEX, it's a little bit more geared towards the disease process with meds. And don't put too much stress on yourself, like how in the heck am I going to remember all of these things? I was terrified, like how am I going to memorize all these meds for the rest of my life? you're gonna be like, oh yeah, there are some times I have little songs for some meds, and there are some times that I will go, I'm like, oh, I haven't heard this med since nursing school, and I'll remember the song I sang for it, and I'll be like, in the little AccuDose, like singing my little song for it, and then I'll text my bestie from nursing school and be like, remember this, you know? It's always the best, it's fun. So just don't stress out too much about meds, and knowing you will get to know them. And guess what? Your pharmacist is your very best friend. They are so nice. They like to answer questions. They like to teach. A lot of the hospitals nowadays have the Voceras, right? So I'm always like, call pharmacist. Ask him or her a question, and they will tell you everything you need to know. But the other good thing about our systems, our EMR systems too, is you go into your MAR, right? Yeah, there's a little link on every med. You press it, tells you everything you need to know about that med. So it's kind of nice. Like we're nursing at the right time of our lives, right? Like we were born into this at the right time. I can't imagine not having any of those resources back in the day, right? That's why people died. So it's kind of nice that we have that. So these are just things to think about. Also, the other thing I want you to think about with your IV insertion, you could be a nurse for 2 days, or you could be a nurse for 30 years and still miss the vein, okay? It's not necessarily based on can I get it or not. It's just the whole process of it. And I want you guys to think of it from the moment you open up your IV start kit, okay? Because how many of you can open up your IV start kit and know exactly what you're doing? Most of the time you look at it and you're like, what am I doing? I don't know. Which side does this go hook onto? And then you open it and you're like, oh crap, I hooked it to the wrong end. I opened up the wrong end, it's the wrong one. Gotta go get a new one, right? So in this process, in simulation, like I said, it's not about going fast. I want you to think through the process so that when you do give an IV, that you're like, I got this, because the IV start kit doesn't even scare me. Like, I know how to use this stuff in here, okay? So think about those things, because we're so worried about the actual insertion that we forget about all the other parts of it, right? Or like taking off the tourniquet, because you're so worried about getting that IV in, right? And they're like, yeah, it's a good one, look at all that blood, and their hand's purple. Yeah, there's a lot of blood for a reason, right? Take off that tourniquet. So thinking about the whole process, I want you guys to think about all of those steps, because it's gonna help you be less nervous and less in crisis mode when you're taking care of patients. You guys, the first time I placed an IV on a patient as a nurse on my own, it was the ugliest IV. But that patient and her husband thanked me over and over again because I faked it till I made it, okay? When it comes to your confidence, don't be the nurse that's like, this is my first time, I've never done an IV on a real person, right? Or whatever, don't be that person. Just like when they ask like, oh, have you done this before? Oh, totally, because in your head, you've done it a lot of times, right? Like you go to sleep and you think about inserting an IV, or you've done it on those arms a lot of times. And so I'll just like, you know, like change the subject or whatever. But I had this patient, this first one, I was like, I can do this, I can do this. And there was nobody there to help me, but I was like, I kind of didn't want help. I was like, I can do this, right? So I go in, and like I said, it was ugly, but it worked, it was functional. And I was struggling a little bit, and I just was like, oh, honey, we need to get you some fluids. Like, you're a little dehydrated. So I kind of put it on her, like it wasn't my skill, lack of skill, or not necessarily skill, but lack of not being able to get her vein versus her veins weren't so great, right? And I'm like, let's get you some water, let's warm you up a little bit. And I did those things, and I got it. And the husband was like, you are so great. Thank you for helping us. No one's ever done that before. Like, that's awesome, right? Or if you let them know, if you're like, oh, you're a hard stick, huh? They're like, yeah, people love to be a hard stick. So if you tell them that, even if they're not, then you've got that in their head, and then it's not you, it's them, right? So you got to manipulate. This is my mental health coming into play. Manipulate the situation for good. Keep your patients safe. Don't fake your skills, but fake your confidence, okay? Pumps, and I'm going to go into more in depth when we're done with this. So with our pumps, in labor and delivery, we use LR a lot. So in our simulations, we'll use either NS or LR. Those are our big ones. Mag sulfate. What do you guys think? This is a little tricky. What do you guys think we use mag sulfate for? Some of you work in labor and delivery, for labor and delivery. What do we use mag sulfate for?
Seizures.
So which would be what? We're using it to prevent seizures. Preeclampsia, okay? So preeclampsia. So preeclampsia is my diagnosis pretty much of like intense high blood pressure, which you guys are going to learn about with Joyce and in this class a little bit more in depth later. And eclampsia means seizure. So preeclampsia is before seizure, right? So my blood pressures are so high that I might seize, and it's fatal for mom, okay, and baby if mom dies before baby. Have any of you seen Downton Abbey? Anybody watch that one? There's a really actually great, it's sad, but it's a really good depiction. It's like in the 1920s in England of one of the sisters who delivers at home, and she has preeclampsia. They didn't know at that time, and she ends up seizing and dying. But they actually depict the situation really well. I was actually really impressed by it. I was like, oh wow, that was really good. Because I can't do grays because no doctors take their patients to the bathroom. It doesn't matter how nice the doctor is, they don't take their patients to the bathroom. So Grey's Anatomy is out for me. I just can't. It's just too much. I just can't do it. So our mag sulfate, because what does mag sulfate do to our body? It closes everything down, right? Pretty much. So we have to be really careful with our mag. This is probably one of our most high maintenance patients in labor and delivery, is putting them on mag, keeping baby safe, keeping mom safe, while we keep their blood pressure stable until they can deliver, okay, at the right time. Pitocin, what do we use Pitocin for? Oh, I spelled that wrong. To induce labor, right? It contracts. Pitocin or oxytocin, same thing, okay? We make it in our bodies, helps mom to contract, to deliver. It also helps after delivery to help contract the uterus to decrease our risk of postpartum hemorrhage. It also helps with breastfeeding as well. Oxytocin, when we release oxytocin, it tells our body that we want to create milk for our baby. Blood will go through at the end of the semester, and then antibiotics. Why do you think? There's two main reasons why we use antibiotics in labor and delivery. Why do you think?
If they have
the
B, right? It starts
yep,
with the
GBS.
Yes.
Okay, so group B strep. So we do a group B strep test in pregnancy at about 36 weeks. It's a vaginal and anal swab. It kind of just checks for bacteria in that area, right? Baby's coming through the canal. If mom is group B strep positive or GBS positive, then we like to dose mom with 3 to 4 doses of antibiotics before delivery, so that baby doesn't get sick and doesn't contract any of the strep. So we'll do antibiotics for that. And then we also do it prophylactically for C-sections. So after mom has a C-section, a lot of times doctors are going to prescribe antibiotics just to keep mom healthy right after surgery. Foley catheters, I kind of told you a little bit about catheters. They're way easier to place in labor and delivery. But that being said, how many of you feel comfortable with catheters? Any of you do them regularly? Okay, so it's usually a little bit easier on a guy because it's external. So even if the hole's not in the right place, you can find it, right? Because it's like in your hand. You're like, okay, let's find this. And but with girls, I'm telling you, not all holes are created equal, and they are not all in the same place. So it can get a little tricky, especially in postpartum. When the frappe button, right? Remember, things all over the place. You just never know. Or mom is super swollen or whatever, right? So you just never know. But labor and delivery, it's a little bit easier. I want, especially because you all haven't had a lot of practice with Foleys, that's something I want you each to like kind of practice this semester, is getting those in, because you'll do a lot of Foleys. And once you get them done, like once you do them, you won't feel as nervous, right? I think that for the most part, you guys really stress with sterile technique. That's what you're stressing about the most, is like keeping things sterile. And then like once you do something, it just becomes habit, right? You get a little bit better at it. And I don't want you to feel nervous. That's another thing. I had a new nurse I was orienting, and she comes to me and she's like, I have never done a Foley, or I think I was charging that day. She's like, I've never done a Foley on a real person. I haven't done it since nursing school, and it was on a mannequin. She's like, and my patient needs a Foley. Can you help me? It's like, yep, we're gonna fake it till we make it. You know how to do it, right? And she's like, yep. I'm like, then you fake your confidence. You don't tell her you've never done one on a real person, right? So we go in there, and I'm just in there talking to the patient, kind of distracting them. She's doing her thing, kind of nervously giggling, right? But they don't know that. Like, we're just like all talking together, and she does it, and it was beautiful, and she did a great job, and I just made her feel a little bit more comfortable. The patient didn't know it, didn't know that was the first time she'd ever done it. So just like manipulating the situation so that the patient feels comfortable and you feel comfortable, because it works better that way, right? But the more practice, the better. The one thing I do like to tell is something I learned in nursing school as well. If you're having a hard time finding where to place that Foley, have your mom cough, or any female cough. If you cough, it'll wink at you. A little sphincter will wink at you. Mm-hmm. So that will even happen. That will even help when my mom's all swollen or cut up too. Like, and I'm really struggling. I will have them cough, and sometimes a couple times, and it usually does. That really does help me. I had a patient once, like I said, they called me the Foley Whisperer. So I had a patient once in postpartum, and I was struggling. This was like, I was feeling defeated because I could not place that Foley. I was like, I don't know what to do. Like, I cannot place this Foley. It just kept coming out, looping around a different way, and I'm like, I can't. So I called the OB to come in, and it turned out that the OB actually stitched over her urethra. So I felt a little bit better about my skills because there really was no urethra there for me to find. It was stitched over. She felt so bad. It's because this girl was one of those ones that was all torn up. And she's like, oh my gosh, I feel so awful. Like, so she just went in and restitched her up and stuff like that. Yeah. But I'm like, hey, it wasn't me. I know, right? I know, exactly. Well, she couldn't pee, so we gotta figure, you know. And in labor and delivery, you want them to pee within 4 hours. So thankfully we check for those things, right? Assess for those things. So we will go over catheters and practice catheters in our simulations. IM injections. I know you guys did this in lab, like barely. It's kind of hard because some of these things, unless you're like an MA and you're doing IMs all the time, it's just practice really, like getting in the practice of things. But there's these slides that are good that kind of show you, that kind of remind you where to go. Deltoid we use probably more than any other site, right? Especially in adults, we use the deltoid all of the time. So I like these slides because it kind of shows you if you struggle a little bit, you can practice at home, look at it and just like kind of find it. But really the mediast area, that's what I usually look for. I usually like pinch and find the mediast area and go from there. Vastus lateralis, same thing, but we, like in adults especially, like we use the vastus lateralis more in kids. So if you're doing peds, this is where, you know, their little arms are so skinny and usually we can at least find a meaty part on their legs. The ventrogluteal, in the kind of right there in the hip, and that kind of shows you how to do those ones. And then our dorsal gluteal, which we don't do anymore, okay? So no more in the butt. Remember back in the day, like you'll hear your grandparents say, like, I used to get shots in my butt all the time, right? So there are too many risks of sciatic nerve damage in the dorsogluteal area. It can cause like paresthesia, sensory loss, and even some paralysis in that area. So we try to stay away. We used to always do our ROGAM shots for our RH negatives moms in the dorsogluteal, and we don't anymore. We just do them in the deltoid usually. So. And they used to always complain about the pain of these ones. I'm like, yeah, they got the freaking sciatic nerve right there. You're like going numb. Some of the medications, these are two that we'll talk about later in postpartum hemorrhage, our Methergin and our Hemabate. If I'm giving an IM injection out of a glass vial, how am I drawing that? What do I need to do that's a little bit more specific? Filter needle. Okay, our filter needles are red, like they come in a little red case. So you'll see those ones. Those ones will take out any microscopic glass pieces, okay, from breaking those vials. So we always use a filter needle when we're giving our IMs out of a vial that we broke. Medications, these are, we're gonna have more medications than this that will come up in our scenarios, but these are our main meds that we use in labor and delivery. So our pain meds, honestly, so easy. Ibuprofen, Tylenol, Percocet, or Lortab, right? We're using our hydrocodone, oxycodone, Tylenol, ibuprofen. Those are our main meds that we'll use. We do every once in a while with C-sections, you know, you're a mom that's like, I can only take IV Dilaudid. That's the only thing that works for me, right? You're always gonna get that patient, but for the most part, this is what we use. Stool softeners. Stool softeners, for those of you, how many of you have had kids in here? Okay, so a few of you have or been there or at least know how it goes. Stool softeners, the first time you have that first bowel movement, not fun, okay? So you've been taking maybe narcotics, you're constipated, you're healing, and it's almost more painful than having a baby because you don't have an epidural with this, right? So I always tell my patients, I'm like, you're gonna praise my name the first time you poop because you're like, thank you for letting me or for making me take my stool softeners. So this is an important part of our care. The little red pill changes your life. Our P&V is our prenatal vitamin, and we usually encourage moms who are breastfeeding to continue with their prenatal vitamin. Our postpartum hemorrhage meds, which we'll go into more detail with. And then we're gonna see a lot of patients with other things, right? Other issues, home medications, thyroid, antidepressants, and anti-anxiety, which we'll talk about next time more in detail. Blood pressure, and then our diabetes. Those are like our main ones that we usually see. Every once in a while, we're gonna get a mom that has some weird autoimmune disease, right? But we don't need to know their meds. Like, that's what this pharmacist is for. And a lot of the times, those patients know their meds anyway, pretty well, so. And then fundal massage, which we call crede. This is really essential for our postpartum assessment, and it reduces the risk of hemorrhage. So we kind of talked about how Pitocin contracts our uterus, right? So when we breastfeed, moms usually start cramping because their natural, their body is telling them that they need to reduce the size of their uterus so that we can lower the risk of postpartum hemorrhage, okay? So also we can do that manually. So we do crede. It's no fun after you've just had a baby and now we have to go knead on your stomach, right? We're like kneading so hard, yeah, it hurts. And then if you had a C-section, you've been cut on the inside and the outside, that can be really painful too. So we're really careful. When we do the head to toe assessment, I'll show you those things. But we find the top of the fundus, and what is the fundus? Fundus is the top actually. So the fundus is the top of your uterus, okay? And after delivery, postpartum, usually you're gonna be at the umbilicus, okay? Maybe a little bit above, maybe a little bit below, but that's usually where we start, is at the umbilicus. And so we're gonna find the top of that uterus, and then we're gonna find the bottom, and then we massage on the top of it. That's how we do our manual contraction or our crede for our postpartum assessment for our patients. And then we actually check for like discharge, bleeding, that kind of stuff. And we'll go more into detail later. Deep tendon reflexes. Why would we use deep tendon reflexes? Which med are we giving that this is going to be important for? MAG, okay? And I'll teach you guys how to do DTRs and even how your DTRs can be an assessment to diagnose like MAG tox, right? So, because, and I say this a lot in simulations, a lot of times with new nurses, especially in students, you guys are looking for you want, what's the word I'm looking for? You want the like tangible things, right? So you're looking at like your labs, like, okay, well my labs are telling me this, this, and this, right? But really it's our assessment and our symptoms, right, that are actually diagnosing, right? Or that are showing us what's going on with our patient. Our labs usually will just confirm those things, but sometimes by the time we get a lab, it's too late at that point, right? So we want to intervene based on our assessments. That's why assessments are so important. So, and you'll learn that a lot in 195 as well. And then blood administration, which will be the last one. We'll talk about blood. Blood seems intimidating. It's a big thing, right, to get a blood transfusion. But I'm hoping that you guys will feel like you have a good grasp on it from this class, because it doesn't have to be scary. It's actually pretty basic. It's the same thing every single time. We don't veer from how we do it. It's the same process. So if you feel comfortable doing that, then it'll be great once you get onto the floor, because even if you work on a floor where you don't give it very often, you'll probably at least give it once in your career, right? So it'd be good just to have kind of a basic knowledge on like, okay, I know how to do this. Like this isn't as scary as I thought it was gonna be. And we'll go through that whole process at the end of the semester and how to set it up and all that kind of stuff. Okay, I'm gonna go over the pump. The pump is, I think, the most essential part for you guys right now. So first of all, I don't know if I can, I'm actually gonna stop this and then